Thrombosponding type 1 domain containing 7A in idiopathic membranous nephropathy. Definition: idiopathic membranous nephropathy is an autoimmune disease in approximately 70% of patients. It is associated with autoantibody against the phospholipase A2 receptor 1. Antigenic targets in the remaining patients are unknown. This is a first video, membranous nephropathy, new insights regarding pathogenesis.
5% of cases is secondary to systemic autoimmune diseases like lupus, infections like hepatitis B, drugs or toxins such as non-steroidal anti-inflammatory drugs or mercury, and certain types of solid cancers. So how do these deposits form? The general principle is that antibodies in the bloodstream need to cross the GBM, the glomerular basement membrane, to target protein antigens that are present beneath the podocyte. Early views in the 50s and 60s suggested that circulating immune complexes were responsible for many of these immune complex disorders in kidney disease. In order for that to happen, these large circulating complexes would need to bind probably on the capillary side, dissociate, cross the GBM, and reassociate on the podocyte side of the GBM. There's minimal evidence for this in humans, although perhaps the circulating complexes in lupus might play a role like this. Animal models developed to study membranous nephropathy involved injecting animals with proteins that were derivatized to be positively charged, for example, cationic bovine serum.
Pros and cons. In 2009, the phospholipase A2 receptor 1, a protein that is expressed in glomerular podocytes, was discovered as the major antigen involved in the pathogenesis of idiopathic membranous nephropathy, as confirmed by a number of subsequent studies. About 70% of patients with idiopathic membranous nephropathy have circulating autoantibodies against. This is a second video, membranous nephropathy, new insight regarding diagnosis.
My name is Fernando Fervenza. I'm a nephrologist from the Mayo Clinic in Rochester, Minnesota. My topic is membranous nephropathy, new insights regarding diagnosis. Idiopathic or primary membranous nephropathy is the most common cause of primary nephrotic syndrome in Caucasian adults. The U.S. incidence and prevalence is estimated to be between 3,000 and 200,000 respectively. It's not a quite benign disease in the sense that approximately 40% of the patients will eventually develop end-stage renal disease. It remains the second or third cause of a primary glomerulopathy leading to end-stage renal disease. But the other issue with patients with membranous nephropathy is that those who remain nephrotic are also at an increased risk for a thromboembolic and cardiovascular events. Diagnosis increases with frequency after the age of 40 years. It is much more common in males than in females in all adult groups, but is rare as a primary diagnosis in children, accounting for less than 5% of total cases of nephrotic syndrome in this population. Now, as we will see later on, primary or idiopathic membranous nephropathy account for 75% of the cases in adults, while the other 25% of the cases are membranous
Risk for renal failure. In addition, patients who have membranous nephropathy with nephrotic syndrome have significant morbidity and mortality, in particular related to thromboembolic and cardiovascular complications. There is no specific treatment for membranous nephropathy. Supportive care be the use of diuretics and angiotensin-converting enzyme inhibitor in combination with angiotensin II receptor blocker is recommended, but these agents have only a limited effect. Immunosuppressive treatment options include the use of corticosteroids, alkylating agents, cyclosporine A, tacrolimus, and mycophenolate mofetil, but their use is controversial. Not all have been shown to be effective, and their use can be associated with significant adverse effects. This is another video, clinical trial in membranous nephropathy.
And today I'm here to introduce you to a new study we are conducting in patients with membranous nephropathy, aiming to evaluate the effect of therapy with rituximab versus cyclosporine in patients with membranous nephropathy and nephrotic syndrome. Membranous nephropathy is a common glomerular disease. It's the most common cause of nephrotic syndrome in Caucasian population, and because of the severity of nephrotic syndrome in patients who do not go into remission, there is a tendency to progress to damage and resulting in end-stage renal disease, and 40% of those patients will need either dialysis or transplantation long term. Now, the best prognostic factor for patients with membranous nephropathy is, in fact, a remission of proteinuria. And as illustrated by these slides, patients who go into complete remission, meaning no protein in the urine, they have an excellent long-term outcome. But even patients who have like a partial remission of proteinuria, meaning that the proteinuria goes to levels below 3.5 grams per 24 hours, they still do excellent long-term. But if your proteinuria remain on the nephrotic range, then the outcome is very poor, with 80% of the patients really going to require dialysis transplantation long-term. I think there is no question that the target of therapy for patients with membranous nephropathy is remission of proteinuria, because we know that if we get rid of the proteinuria, those patients will do very well long-term. Now, we do
Conclusion: Idiopathic NN is a glomerular disease usually of abrupt onset and associated with the NS. Control of the NS, specifically CR or PR, is associated with prolonged renal survival and a slower rate of renal disease progression. There are no standard or universal first-line specific therapeutic options for idiopathic NN. Supportive and conservative care should be given in all cases and should include the use of ACEI and ARB therapy as well as a lipid lowering. If patients who are at low risk for progression, this approach should suffice, given their excellent prognosis. These patients need to be followed long-term to ensure that there is no deseparation. Thank you for your attention.